clearly I will be the one standing between you and lunch, but it depends on how many questions you have. Just to quickly summarize that, we've had, 4 very good presentations, different challenges. Zanzibar, a much smaller population, but, you can see that, peculiar challenges. Low antenatal care attendance. They have introduced digital data capture systems, which enables them to pinpoint what the problems are and where the problems are, helps them to focus those interventions. The good thing, which is quite reassuring to those of us who have lost our immunity to malaria, is that malaria is low on the island. Prevalence, HIV is quite low on the island, but anemia remains a problem, anemia in pregnancy, and these they are trying to address. And if you remember from the speech of the First Lady this morning, our foundation is really looking at improving the nutritional status. Really, from those items that are available in the island and do not cost so much, but you can address those issues of anemia. So a really comprehensive approach here, investing in infrastructure, new healthcare facilities that have come in very close to where people live, and a package where they remove financial access to care for women and newborns so that we can improve attendance. But also, quite importantly, recognizing the influence and the role of males in reproductive and maternal newborn health, including them in the health education to try and address some of these issues around low contraceptive prevalence rates, low family planning, and poor nutrition indicators. So join me to thank Dr. Slim again for an excellent presentation. Good. So I think we're happy to take 1 or 2 questions or comments from the floor before we break for lunch. I think by now I've made you end your lunch. Yes, Maria? Do we have roving mics, or how are we going to manage? Any microphone? Or we use the same one?
Thank you very much, Professor Amen. I would like to thank the directors for such good presentations, but also for all the initiatives that they are putting into improving reproductive, maternal, newborn, and child health. All of you commonly have mentioned quality of care being pivotal in improving the mortality and morbidity rates in all the countries. My question to you all, or whoever will be ready to respond, is that how best then do you think we can measure, or what are the best indicators for quality of care in reproductive, maternal, newborn, and child health? What indicators should we use?
Thank you, Maria, for that very inspiring question. One of the most difficult parts of knowing whether we're providing quality of care is what indicator to put in place. But I'll try to attempt to answer that question. First of all, quality relies mostly on the qualitative indicators. And to design qualitative indicators, again, they are the most difficult ones to be designed. The best what I would say is, first of all, you need to have a set of indicators to approach that question. You can't say one indicator to tell you whether quality of care, you have attained quality of care. For example, let us take an example of a woman who is attending a antenatal clinic. She should be coming in the morning, she should be preparing herself going to clinic. When she reaches at the clinic, the question when she exits from that clinic is, were you satisfied with the services you received? That is one of the questions that can give you a sign whether that woman had some kind of good care experience. But this does not mean she received a good service. That means the coverage of service within the antenatal care, based on the available package of the services, whether they are complete or not complete, will determine whether that woman received quality of care. But again, receiving those services does not mean that she received the quality of care. How those services were delivered by the provider she met is extremely important in terms of defining the quality of care. Even at the receiving door, when she's being received, it does distinguish between the quality of care and whether she just went there and received the service. And that would determine your favor you are giving her, whether she's going to use or she's going to throw them. Because if you receive it very well, you are trying to cancel her. You are trying a two-way indicator, telling her pros and cons of taking the favors. If you are able to explain, then you are reaching that area of quality of care. So there are so many indicators. You can't say that you have a single indicator that will define your quality of care. That's the best I would say. I support.
And he presented the WHO Quality of Care Framework for Maternal and Newborn Health that showed us about the structure, process, and the outcome. And from what Makwani has said now, there is that perspective that comes from the woman herself, her experience of quality. And if you talk to women, at the end of the day, the reason why she probably wants to take her chances at home is because that her friend or that TBA she calls will treat her nicely. The healthcare worker may shout at her, "Why did you come late? Was I there when you were doing it?" Slap her and all of those things. So that experience can determine whether she advises her sister to come or whether she comes the next time. And you can only know from her. The other which he has talked about is the structures we have in place to provide good care. Is it up to the minimum standard? That way you can measure the quality as well. Then the process of treating or preventing that postpartum hemorrhage, is it based on the best available standard? What proportion of women did we prevent PPH based on the best available standard? Of those ones who had PPH, what proportion of them had the treatment based on the best available standard? So it can be a complex question. But he started by saying, at times, quantitative indicators may not do the trick. You may have an in-depth qualitative discussion to be able to unpack exactly what the issues are, to be able to respond. So I think you will agree that the starting point is to understand what we are dealing with, and then you know how to apply it and to respond. But I think the WHO has tried, and I'm not sure they've succeeded, in coming up with a simple tool to measure quality of care. I remember the last attempt. The thing was a near textbook that is practically at the healthcare facility level would maybe too difficult to use. Okay, so we can continue over lunch, but I give Dr. Real the last say, and then we can continue discussion over lunch.
Thank you very much, directors, for the good presentation. I just have two questions for the Nigeria colleague, Dr. Jumbo. You've brought the elderly into your RAMCA. Now the question is, which aspect of the elderly care have you brought in? Because I had expected you to leave that to the NCD people to do. So maybe you will explain exactly that. And then my other question is to Professor, because on the issue of NPDSR, we know that the perinatal and audit of perinatal deaths is already just not happening. So I don't know when the child now has been brought into the picture, how does that pan out? Thank you.
Okay, thank you for the question. One of the things we are looking at when it comes to RAMCA is...
May I call upon the three speakers to take the front seats. Karibu sir.
Coverage and then the Every Newborn Action Plan and the Ending Preventable Maternal Mortality targets became important targets for the work that we've been doing, as those targets can show. The improvement in quality of integrated and PNC services we know is key to accelerating progress, and this is the focus of our program, especially our QI program. And like I said at the beginning, the essence of our pre-intervention baseline study was to guide the design, implementation, and monitoring of interventions. And the objectives were to determine the availability of infrastructure to provide NCPNC integrated services according to national and global standards. And we wanted to also know availability of medicines, supplies, and equipment that are essential for those services, as well as determine utilization of services. And the overarching objective was to inform the design and implementation of the QI program. And what we did was a cross-sectional survey using a tool that was developed by LSTM and adapted to the different contexts where we were working. And as in all implementation programs, this was a co-created approach, which is an important thing we want to emphasize and highlight in this. It's been coming through in all our discussions that this is not about set of intervention. People came to just come and impose on the context. It's beginning with discussions and agreements with all the different stakeholders in terms of what we want to do. And then this was based on the questionnaires that we used to cover those three modules. You can see there around availability, readiness, and quality of care. As Professor Charles has shown earlier, our work is based in 4 sites, and you might hear me sometimes unconsciously say 4 countries, so I don't want to cause political problems. So there are 4 sites. So in Nigeria, Kenya, Tanzania, mainland, and Zanzibar, and those are the numbers of health facilities where we were based. You can see it's a very small, relatively small fraction of health facilities where interventions are based. But then it's a very important opportunity for us to know what works and what could be scaled up. So this just tells us, in terms of the scope of my presentation, the work, the baseline assessment I'm presenting happened at different times because the implementation of the program began first in Nigeria. The baseline assessment in Nigeria was in 2020, in 2021 in Kenya, and around 2022 in Zanzibar and Tanzania mainland. And in terms of the facilities where the baseline was based and where the intervention is based, this is the sort of characteristics that mostly what we refer to as primary healthcare level facilities or low volume facilities, which cater for a substantial number or population of women that need these ANC and PNC services. And another important feature of these facilities is that the overwhelming majority are actually owned by government, so publicly owned. And that's important. When I was listening earlier to people talking about health financing, and when people need to go to government places, rather than private places. And what I'm just highlighting from here in terms of availability of NCPNC providers is that if you look, sorry, I didn't highlight it. So the percentage of health workers that we found at baseline that could provide NCPNC services varied from a small number in Nigeria, 32%, to very large number or proportion in Zanzibar. This is in terms of those at baseline found in the health facilities that can provide NCPNC services. So just to sorry for going back and forth, just to say that I think was said earlier that the distribution of the specialists is variable across the continent, and in the set of facilities where we're working, you can see that there are more specialists in Nigeria than elsewhere, even though overall the proportion of health workers that provide NCDS services is least there. So what I want to show from here is in terms of selected essential equipment, and Professor Charles hinted on this as part of our intervention. We found at baseline that even though things like measuring tape, like adult BP and fetoscope tend to be available in an overwhelming proportion of facilities in a place like Tanzania, for instance, no place had full availability of, or universal availability of the very basic equipment. You would have thought that every health facility is going to have all these things, but we can see that even EDD is about 16% of facilities, for instance, in Kenya that had it. And when you look at something like our weighing scale, if I look at Nigeria, for instance, about 64%. So this is an important gap that we found at baseline. There was no universal availability of essential equipment. And here, just looking at the training provision at the level of health facilities, even though we can see that something like 80% of facilities in Zanzibar, for instance, tend to be providing training in all these areas that we highlighted, like HIV, malaria, gender-based violence, and all that. We can see from here that when it comes to mental health and respectful maternity care, we found that there was least opportunity for training in these areas at baseline. And in terms of guidelines, what I'm highlighting here, again, is buttressing the point from the previous slides, that yes, guidelines are not universally available in all these areas, but when it comes to respectful maternity care or maternal care, that's still about the least available guideline across the different sites. And for HIV counseling, diagnosis, and management, I picked on infectious diseases because this is what our focus is on, integrated infectious diseases services, ASC, PNC services. So generally, it will look like, and we can see there's relatively high availability of HIV guidelines across countries, as is expected, even though when it comes to the specific one guideline in HIV diagnosis, there are several of those. It's not the same across everywhere, slightly lower in Nigeria. And for malaria guidelines, again, I mentioned at the beginning, one would expect that if you're in a malarious area, like most parts of sub-Saharan Africa, there should be 100% availability. We can still see that there are gaps in availability from treatment to diagnosis for both TB and malaria across the different countries. So when it comes to tests that are done, again, there's variable availability across the different sites when it comes to the different testing kits and testing methods available. So even though we have up to about 100% of facilities having these tests across Tanzania and Zanzibar, for instance, we can still see that there's no testing, no availability of syphilis testing, HP testing, and more importantly, I singled out gene experts here, even though someone would argue that it's not expected that gene experts should be everywhere. But if we're talking about integrated TB, HIV services, we should now be thinking about gene expert availability in many facilities, given the fact that now it's the game changer in TB control in the high burden areas. and is supposed to be the first level of diagnostic. And within 2 hours, you can get the results. Not only getting a result, but getting to know whether there is any indication for resistance. So when it comes to service utilization, 2 things I want to highlight here quickly have been shown earlier, that even though we might have high numbers of people attending ANC, attending PNC, we still have very low proportions that attend the first antenatal care at the recommended time across the countries, and the same goes for PNC within 48 hours. So, interestingly, you're going to be finding throughout our presentations here that some of those proportions are over 100% in Tanzania mainland, and this is one of the things we try to clarify. And part of the explanation is that there are numbers of women who don't deliver within facilities, but they come to the facilities for PNC and they are captured. So when it comes to maternal and newborn, there's also highlighting 2 things. We still have relatively high stillbirth rates, and even though somehow at baseline, the neonatal mortality rates in the facilities where we worked was much lower than the EMAC targets. Okay, sorry, my slide wasn't moving well. Sorry about that. So just quickly to highlight from what I have said, I think I've discussed this along the line. I think what I want to bring up from here is that ANC and BNC attendance was lagging behind, and even though we have relatively high testing rates, this might be because of the particular services. So we've got the HIV program, malaria services that would have contributed. I think the important thing I want to highlight are some of the limitations, because we need to understand that about the data. At baseline was born prevalence with a relatively number of health facilities, a 1-month data collected from health facility registers. So we cannot guarantee the accuracy and reliability of these things, of all of them. The methodology was as the WHO ZARA, availability of services, and they didn't take into account the critical numbers of training that we took into account. So for instance, when you say training in a facility, what does it mean? In our intervention, we are defining training as at least 80% of all health workers that are getting that training, so 80% saturation. And the survey was designed only to identify key gaps in availability of essential equipment and consumables. And so details of all services provided in healthcare facilities were not captured. And importantly, you'll notice that women's perspective was missing, but this is an important thing we've tried to capture in the intervention program. So in conclusion, there were gaps in equipment availability, as we've shown, as well as in training opportunities and ANC attendance. And it was these gaps that justify the sort of interventions that we came with our program that we hopefully hear about further down the line today. And it's important that ongoing stakeholder and policy engagements continue for sustainability. And it's important to also highlight, like I mentioned at the beginning, is the co-creation. So we acknowledge the government stakeholders and every other person that contributed to both the baseline survey and its success and the interventions that were designed from there as an important lesson in co-creation. So thank you very much.
Thank you very much for this presentation, which highlights the baseline assessment of what was present when the program was starting in the 4 sites it has been put. And you can see from here there are issues on availability of ANC and postnatal care, equipment, commodities, and it varies from one country to another, but at the end of the day, you can see countries are struggling to provide services, and possibly this is a call for all of us to see how best we can fill this gap of availability of those issues. Now maybe I call upon Alice Landu so that we can take the podium to tell us about the creation of innovative ANC and PNC capacity strengthening program.
Thank you so much. Good afternoon, everyone. I'd like us to take 1 minute to stand up and just touch on our shoulders. In 1 second, if you all stand up and touch on our shoulders. If you're able to touch on your shoulders, then you can humbly sit down, please. You can humbly sit down, please. Thank you. Thank you to our hosts, the team from SUSA. We are very grateful. We've received indeed a very warm welcome, and we are deeply appreciative of that. And we're also thankful to the team in Dodoma for the warm welcome as well. I'd like to draw attention to our work, which has really been the work of many stakeholders, which some of those that Dr. Salma highlighted on in the morning, the importance of sustainable collaborative work, and this is one of the outputs. And we'll be sharing on the co-creation of the innovative ANC and PNC capacity strengthening program. My name is Alice Landu, and I'm a postdoctoral research associate. I'm based in Liverpool. So briefly, I'll go through some background information, and then I'll take us through what this course looks like and share some experiences, and then wrap up with some concluding remarks. I'd like to thank representatives from the Ministry of Health that from the previous session, they really did an excellent work in highlighting and echoing issues around quality of care. And we cannot really overemphasize the aspect around quality of maternity care, given the high number of deaths that occur within the health facilities in low resource settings. And one of the strategies we can, or one of the reasons behind the poor, adverse MCH outcomes at health facilities has been alluded to inadequate health worker training. And from the literature, it's been shown that it's possible to bridge this health worker capacity skills in terms of the gaps that are there through strengthening the capacity of health workers involved in service provision. So LSTM designed a 5-day competence, LSTM in collaboration with partners, various stakeholders, designed a 5-day competence-based package to train health workers who are involved in ANC and PNC service provision. And this varied across 3 countries, or the 4 sites, in Kenya, Zanzibar, mainland, Tanzania, and in Nigeria. And the mode of delivery was through face-to-face, and through lectures, case scenarios, and demonstration of very practical hands-based skill sessions, with the overall aim to strengthen the capacity of health workers in the delivery of ANC and PNC service. In designing the ANC-PNC course, we drew on one of the educational models known as Bloom's taxonomy, and this was largely to ensure that the learning outcomes were indeed fit for purpose and were able to impart knowledge and skills for the health workers. And as I mentioned, this was a work that was collaboratively done by a multidisciplinary team from the 4 sites. And we took into consideration also the country guidelines and other in-country contextual factors in adapting this course. So this was between 2017 to 2020. However, we all remember the year 2020 because of the COVID pandemic and the restrictions that came with it. This also brought us back to the drawing board to reflect on the modes of delivery, which was largely face-to-face, and to repurpose this into a blended learning format, which I will be sharing in subsequent slides. So the first part of the blended learning ANC-PNC course involved the self-directed learning, and really the key aspect around this is that individuals learn at their own time, and they're able to access the course online. On your, there's a picture of the ANC-PNC course interface on a computer. So once somebody logs into, they're able to click on the buttons and be able to start the course. The beauty around this is that they have two options, either to use computers or to use their phones. And that was by phone in 2022, trying to test out the ANC-PNC blended learning course, the self-directed part. And they're able to download these resources and really study at their own time and convenience. And they're also able to use this, after this online self-directed learning, they're able to obtain CPD points for that specific component. Once they've completed this self-directed learning, then they move on to the second part of the course, which is known as the facilitated virtual sessions, and these are delivered on Zoom. And I'm happy to recognize and acknowledge the presence of some of our master trainers that participated in the delivery of this course a few months back. So during the Zoom sessions, these are largely case scenarios, and it's mainly to generate discussions, interactive sessions with the facilitators and the participants. And they run for 2.5 hours over 3 days. So the health workers are divided in 4 groups, and there are 4 sessions, and every 20 minutes they're able to be switched from one session to another to learn a new, to have a discussion on a new topic. And once the aspects around the Zoom sessions was that there were 2 faculty members. One was guiding the discussions on Zoom, and while the other person kept an eye out on the chat for any questions, for any comments, and to address any admin-related aspects that would be coming out during the sessions. This quickly evolved into mentorship sessions as well, where they were able to discuss some of the complex cases of participants also brought, or the health workers brought along with them, some of the complex aspects that they were faced with in their work, and those were also addressed either during the Zoom sessions or they were followed on after the Zoom sessions. Then the final part of the course involved the face-to-face sessions, and this was over 2 days, but very intense skills-based sessions, hands-on sessions. And during this time, similar to Zoom, the health workers were divided in groups, 4 groups, and at each session they were able to practice a skill or a group discussion and moved around until the sessions were complete. So in evaluating this course, there were also measures that were put in place to ascertain whether learning occurred, and one of them was through the assessments. So before they started the course, they had a pre-test on knowledge during the self-directed learning part of the blended learning, and during the face-to-face session, they also had a skills session, a skills test. So those were done before and after. And then we also had feedback mechanisms in place that were there through the anonymous feedback forms and through the debrief meetings. And through this, we received feedback on aspects of the either administrative or other content-related issues that needed to be dealt with as they sprang up. And we also created WhatsApp groups, and this quickly evolved into peer support for the health workers and also for the facilitators during this time. To ensure that the courses were completed systematically and that somebody did not skip from the first session to the last and downloaded a certificate. We ensured that the courses were controlled, so you had to complete all the 11 modules on the self-directed learning. And then we also had some research on that. So in terms of feedback from the stakeholders, there were aspects that they highlighted in terms of the course content and the methodology, the training methodology, and also aspects around the relevance of the course content to them. And from Zanzibar, one of the health workers mentioned that the teaching methodology used was quality, and the material was very well summarized and understandable. There were some challenges that were observed as well, and one of them was around the unstable internet. And the other one was really around the scheduling of the Zoom sessions, which were run from 2 to 4, which coincided with the busy time at the health facilities. And the whole aspect around Zoom being a new platform of learning within our settings. And how some of these were mitigated was that there was an induction on how to use Zoom, and also the in-country partners really supported the health workers with going all the way to the health facilities and showing them how they could be able to engage with Zoom, which really helps a lot. And as I mentioned, having evening sessions rather than afternoon sessions greatly improved on attendance as well, and having a dedicated admin support team to support the health workers with any course-related issues. So as I wrap up this discussion, one of the aspects when we were testing out the new part of the blended learning course was to ascertain whether it was acceptable and feasible to be implemented in our settings. And I'm pleased to note that this training is very acceptable and remains a viable option to improve capacity of healthcare workers that are involved in ANC and ENC service provision. I would like to acknowledge all the ANC, ENC package development team across the many countries and sites. And I'd like to say thank you so much. Asante sana.
Some more claps, please. Thank you very much for putting this light to this group about the use of innovation in training and effectiveness in transferring knowledge and skills. But I'm also very much pleased to learn that some of the fixes in the COVID era have been very helpful in terms of serving resources, Zoom. And that has been very, very helpful. Thank you again for your results you have shown us how much in this intervention, competence-based training was innovated to make sure people receive knowledge and skills which they require. And you can see the results, the appreciation of the participants of the training, that the model was very, very useful. Possibly all of us, when we are in this session, we should think how best this knowledge can trickle down to pre-service training. Because here, we are talking about the in-service training. There in the pre-service training, the situation is not the same. And the challenges are many there, are many in pre-service, particularly when you have a kind of didactic training whereby you have a long lecture. Some are sleeping, others are using their mobile phones and expecting that we are going to produce good nurse midwives and good doctors and good lab technicians. Impossible. In that situation, we need to go with the time to innovate so that our transfer of knowledge and skills can be very, very effective done during the pre-service service. Now, may I take this opportunity to invite Dr. Fiona Dixon to take the floor so that can take us through the ANC and the PNC quality improvement using the standard-based audit approach. Karim-san, welcome.
So just to give you a brief overview, I'll talk a little bit about the background and the methods of the course, and then a little bit about the course content itself and the support materials that we developed. And finally, look at how we rolled it out, the challenges we faced, and some conclusions from it. So I think, as we've heard very eloquently already today, improving quality of care is about not just coverage, but actually the quality itself. So to improve health outcomes, we need to improve the quality of care as well as care coverage. And as part of that, within LSTM, we've developed a quality improvement training course. This has been run for several years now, and then successfully. But as with the ASC PNC course that Alice has just talked about, it was felt that actually it would be helpful to actually develop this into a blended learning package in the light of the COVID pandemic. This also has the advantage of making it more accessible and more cost efficient as well. The blended learning approach uses a variety of pedagogic approaches, and I'll talk a little bit more about those in a moment. So the initial step was to review the existing QI course and to discuss how best this could be developed using the three pedagogic approaches that we considered. So the first part was looking at developing the lectures and learning materials or learning activities. And those were spread over the self-directed learning, online group learning, and then finally face-to-face learning. We also developed some support materials to support facilitators and participants taking part in the course. These were piloted, and we also conducted some orientation sessions for facilitators who are either new to the QI course or new to the blended learning approach. So in terms of the course, in terms of the course content, this is a list of the different modules that were included within the course. So we covered a whole range of topics from things like introduction and safeguarding, which is obviously an important issue, to more standards-based audit, re-auditing, mentorship. So a whole range of issues relating to QI and also to training. So the first part of the course
involved self-directed learning modules. These are carried out online, so as the name suggests, the participants access them online and can learn at their own pace. They combine lectures, pre-recorded lectures, with learning activities such as quizzes, reflections, and as you can see on the example that's shown on the screen. They are, again, as the name suggests, carried out online and are hosted for us by the World Continuing Education Alliance platform. And this makes them available not just in our countries, but also to other countries whose Nursing and Midwifery Council subscribe to the WCA platform. They also have the advantage of allowing participants to learn at their own pace. So they could maybe do a short amount of learning each day, or they could sit down and go through it in one go, depending on their time limitations. But essentially they had a 2-week period within which to complete this whole section. The online group learning was carried out using the Zoom program, which I'm sure we've all become increasingly familiar with since 2020. It comprised 3 synchronous online sessions. So these are 3 group sessions, which included not only teaching, but also breakout groups as well. So participants could learn as a group as a whole, but also the smaller groups facilitated more in-depth discussion. Each of the sessions lasted approximately 2.5 hours, with a break in the middle to allow participants to learn effectively and to be able to concentrate. They were led by experienced facilitators, and their aim was to ensure that the information was understood by all of the participants, hence the mixture of group learning, but also the smaller breakout sessions. This felt that participants would be more happy or more comfortable discussing the limitations that they're understanding in a smaller group. So this part of the course looked at an overview of quality, what is quality improvement, and how standards-based audit works. Also the particular methods of carrying out audits, and also a little bit about analysing the data that the audits generated. The final part of the QI course is a traditional face-to-face learning session. This was spread over 1 day and was taught in person by experienced facilitators again. It also included talk sessions as well as breakout groups, and again for the same reason that it allowed participants to feel more comfortable discussing something if they didn't understand something. It also helped to reinforce the practical aspects of QI and sought to address any gaps within the participants' understanding. The other aspect of it was that it allowed the participants to actually develop a QI plan for their individual facilities. So it wasn't just addressing the theoretical concept, it actually helped them to put together a plan that was applicable to their own facility. As part of the course, we also developed some support materials to go alongside it. So there's 3 key sets of materials that we developed, which was the participant workbook, which included worked examples, template forms that the participants could use to actually implement QI standards-based audit in their own facilities. There was also the facilitator's e-manual, which was to support facilitators in running the course, and gave a detailed breakdown of the content of each of the different sessions. And then finally, as I said before, we carried out some orientation sessions online for facilitators who were either not familiar with the QI course or who were not familiar with the blended learning teaching approach. And those were well received. We had several sessions and those were quite useful. So the training materials were initially piloted with a group As I said, we carried out 4 orientation sessions with a total of 58 facilitators. The blended learning QI training was conducted from August 2023 in Kenya, Nigeria and Tanzania and Zanzibar, although the traditional face-to-face QI training had also been carried out in Nigeria previously. Some of the challenges which are similar to those which Alice mentioned just now included things like limited internet access. So obviously if you're carrying out a training course that is predominantly online, then a reliable internet access is essential. Some of the participants also were unfamiliar with using the IT equipment, so they might lack experience of using emails, which would necessary to as a login credential for the WCA platform, or just unfamiliar with navigating things like Zoom on a computer. For some participants, the lack of access to IT equipment was also a challenge. They might have been familiar with accessing it on something like a mobile phone, but if you're trying to read lectures or read material or things like that on a mobile phone, it doesn't always work well, and it's much easier to use on a laptop or a desktop. But it is so nice that everybody had access to those resources. There were also a mixture of educational levels of the different participants. Obviously, it's important to include as many healthcare workers as possible in this training, but sometimes the different backgrounds weren't always an advantage. So in conclusion, the QI course was generally well received, both as a face-to-face and as a blended learning course. But the traditional face-to-face course was generally quite time-consuming, 4 or 5 days out of the workplace. It's likely to be challenging in any facility. And also comes at a cost, per diems, hotel fees. I'm sure we're all familiar with the issues. The QI course allows large numbers of people, or large numbers of participants, in a more time and cost-effective way to take part in the training to access it. It comprehensively covers the different aspects of QI, particularly relating to standards-based audit, and potentially more sustainable over the longer term because of the efficiencies of it. So I'd just like to thank the different members of the QI and acknowledge the different members of the QI team and the funders and the other organisations which have supported this process. Thank you.
Some more claps, please. Thank you very much, presenters. Possibly you need to share some questions. The first presenter, my question is, I could see those commodities, supplies were buying in the facilities. How about its use? In terms of use by the facilities?
Well, thanks for the question. So what's the information that we wanted to capture, the survey was captured, was actually whether those equipments were available and could be seen in the facility, not whether people could use them. So I think it's an important thing to consider that people want to see whether they need to train people to use of equipment. But as you can see, they are very essential that people should actually know how to use. But that particular information wasn't collected.
And the second presenter, my general question is, how far did you engage the colleges? in these trainings and making sure the college, somehow the policy could change in terms of approaching their trainings.
Thank you so much for the question. In terms of engaging the colleges, that was done by our in-country, with support from our in-country teams. Unfortunately, I don't have a number to put to that, but this was carried out within at the country level.
Okay. And on the QI, I understand this is the most, everybody talks about QI, but when it comes to implementation of QI, particularly when it comes to policy makers, buying is another area of a challenge. How did you see in terms of implementing this QI interventions in those countries and the engagement of the government itself?
So, as I said, I've been working as part of a team, and a team within each, we have members of the teams within each of the countries, a big part of the development, but also a very important part of the implementation of the programme, and have close links with the different ministries, governments, and stakeholders within the countries to help them in terms of developing these materials and these activities.
Thank you very much, everyone. Now, may I request the rest of the members to ask any question to these three participants. Please do. There is one hand there, another. Dr. Bashir. There are two only. And then there are another hand there. Maybe we pick all the questions and then we will start answering them. Please.
Thank you, Chair and presenters. My question is, how many cohorts of people have been trained so far? Or is the two courses, are they at the stage of development and has not been disseminated to the different countries? And what is the intention, now that the project is coming to an end, what is the intention of institutionalizing this in the different countries of the study so that we can take it up? The support that you have been giving to the people may not be available in countries, and the seriousness of the investments that LSTM has put in may not be available in different countries. So how do we intend to sustain this for impact?
Thank you, Mr. Chairman, and all the presenters. I just want to better understand on this training. From the presentation we had in the morning, Dr. Makwang addressed the issue of attitude. You mentioned about that. Did this training address the issue of human resource attitude? You know, sometimes you may conduct a training, but if you don't address this, you may come back after 1 or 2 years, they say, we have never been trained. And the second issue was about the equipment which were supplied. In the baseline, there are equipment which are not available, basic equipment which are not available at these particular facilities. So, were they new? Did you go further to our country guideline to see whether all these are available in our medical stores, on our routine catalog, and what were the gaps? Were they available, not due to funds? Maybe you can help us on those issues so that we can address them when I'm talking about scaling.
Thank you. Two questions on quality improvement. The first one is based on the findings. Do you think it is prudent that a curriculum is developed for every cadre or different service providers? For example, you have a curriculum for nurses, for midwives, then another one for doctors, something like that. And then finally, did you do a cost-benefit analysis of all the interventions, quality improvement interventions? Something that someone can use for trying to influence national policy, for example.
Thank you all for the questions. I can see the questions are not directly, asking particular questions. So I'll take the areas that are relevant to me, and my colleagues can talk. In terms of how many people trained, the country leads are going to have statistics on that, the actual numbers that have benefited from these trainings or the different kinds of trainings since the interventions began. And I think they can talk about institutionalization of training, and sustainability of this is going to come under a very big umbrella of the discussion we're going to have from tomorrow and the next. So, but I'm sure that maybe Professor Wame or anyone else can speak to that. But in terms of baseline equipment, whether we check the availability in stores or anything. So when he asked the question, I should have mentioned that, I mentioned in my presentation that we followed for the baseline the WHO Service Availability and Readiness Assessment Manual. So the ZARA methodology does not say whether you should find out why the equipment isn't available. So what was done at baseline is the equipment available? So that's the question. And the next step is, can we see? Those are the two things that SARA allows us to do. So I really can't speak about whether those equipments were not in the facility, but somehow, somewhere in a store in the country or somewhere. But that's an important point to note. So I think for me, that's the area that's the part I wanted to comment
on. The second one is Alice.
Yes, thank you. I would like to respond on the question on staff attitudes. We had in the ANC course, there was a whole session on staff attitudes and around respectful maternity care. And this was evident that after the training within the health facilities from the success stories, I believe some of those will be shared in the subsequent sessions tomorrow and the last day. There was evidence that attitudes had changed, and they were treating the clients with more respect and also with kindness, and also looking at, there was evident change which will be alluded to in some of the stories that are coming from the in-country sessions. Thank you.
Yona.
Thank you. Yes, I think similar to Alice in terms of sustainability, the hope is that the training will be embedded for the QI course. It's only a relatively recent course that we've started doing as a blended learning, so it was only started in August of last year. The standards-based audit approach not only involves training, but then the actual implementation of standards-based audit, which involves a baseline, the implementation of an intervention to address the problem, and then a follow-up assessment. And this takes time over a number of months. So at the moment we are just collecting the first round of data following, and as I've said, we will be sharing more in more detail. But on the whole, it seems to have been well received. The feedback from the trainees has been positive, and also it seems to be showing positive outcomes in terms of the actual standards-based audit. In terms of different curricula for the participants, essentially the curriculum is the same because the participants are taking on the same roles, so they are, although they might be potentially different charters, they're actually essentially doing the same thing in terms of the standards-based audit. It's a team approach. So they're identifying the problem, identifying the implementation, and then assessing whether the implementation has made any difference. So the real focus is on it being a team approach, hence training the different charters together. We haven't as yet conducted any sort of cost-benefit analysis, primarily for two reasons. That, as I said, the course has only recently been implemented, so we've not really had a chance to carry out any cost-benefit analysis. But there is research to suggest, or there is evidence to suggest that, certainly on the face of it, there are cost reductions associated with carrying out blended learning training, as opposed to having to do a full 5-day hotel-based training, including per diems and everything else, time away from work. Also, there are potentially a variety of factors that can influence something like a cost-benefit analysis. So it's not necessarily just a sort of straightforward, this is what the course costs. You have to quantify what the benefits are and what sort of factors might have influenced that. But yeah, as I say, we will be giving you more detail in terms of the outcomes from the program tomorrow.
Thanks to all the speakers, and thanks Dr. Makwani. I just wanted to add a few comments to some of the questions, just to complement what has been said. So the first one is on the sustainability of the training approaches. And I want to give some concrete examples. So the whole idea of designing a blended learning program and making it accessible on a platform that is already used by regulators of the profession in terms of nursing and midwifery and medical councils. In most sub-Saharan African countries, I think it's one of the key strategies for sustainability. So accessing this course and taking it, you can get some of those points you need for re-licensure. So I think that's a very good first step. So that means that the impact of these training courses hosted there goes even beyond implementing countries. But however, I think there's a missing link there. We have a lot of courses, for example, on this type of platform for healthcare workers. But there is no system to mandate somebody who is providing maternity services to take a particular type of course. So that's a missing link. If we want to go far, we may need to close that gap. The next bit of the sustainability I want to talk about is something we learned while designing the ANC-PNT training package. That especially in some parts of East Africa, where Swahili is spoken really is the main method of communication, especially at primary healthcare level. If you don't translate these materials to that language, you don't have effective learning. And so we worked with the universities in Tanzania to translate all of that material and use it in training healthcare workers. And not only just translating that and doing it in slides and the training booklets and all of that, but also available on an accessible online platform. Now, this material is now owned by the university, and they're going to mainstream into pre-service education. So that's another big piece of sustainability. Now, in terms of the equipment, so because of the way we approach things, so in each of the countries, we have working closely with the Ministry of Health, and for the program, there is a steering and advisory committee which is chaired by the Ministry of Health. So that means that any baseline survey, any adaptation of the training material, endorsement before anything starts, it goes through the Ministry of Health. So, for example, baseline survey, you find out XYZ is not available. The Ministry of Health can ask, well, we have procured this thing, it should be there. So that process in itself is catalytic and can help unplug some things. But where that does not happen, we had a small budget in each country to make those equipment available to the facilities. One thing that was universally lacking, some of those point-of-care testing. You want to test HB at the healthcare facility or things like that. Those small machines and things were not there most of the time. So that was something that was provided. Then also talking about the cost-benefit analysis. So we didn't do a cost-benefit analysis per se, but one of the previous studies, which Alice talked about, and she showed you a publication being reviewed in one of the journals, we compared the blended learning cost to the full face-to-face cost, looking at the costing of every element by comparing one country to the other and what are the cost drivers in everything. And if I ask you to guess what the cost driver is in every setting, you will tell me it has to do mainly with DSA, isn't it? We're talking about DSA, facilitator cost and everything. But we are not costing. This is a study. Please, if you can fund your PhD, I'm interested to supervise you for this one. I want to know what is the impact of taking people away from healthcare facility for training. So what are the missed opportunities for care? How many women will die as a result of people going for training? And then when we compare the benefits, materially, nutritionally, to the healthcare workers, compared to the women who they are supposed to be serving, what is that? I think it will be a wake-up call actually, because in some countries, we are really battling to say we should be training people less. We should be taking people away from facilities less. Because the more we take them out, the less available they are to treat the women. So you can decide, is it better to have half-baked people than to have nobody at all? Have you ever been to a primary healthcare facility where during the time of training, the door is locked and there's a chalk has been used to write the mobile number on the door, call me if needed? Can you imagine? So the woman will press pause on labor pain, it's ridiculous. So I think we really need to think out of the box. We have already a severe shortage in terms of manpower, health workforce, but at the same time we need to meet training needs. What is the most efficient way to meet these training needs? So like Dr. Makwania said, we can start by updating pre-service training so that as they come out, the deficiency is not so much. Then because knowledge is always changing and complications are not so common, if you don't practice something for a long time, you forget. What is the best way to remind people? What is the best way to make sure that we have a culture, a continuous culture of learning? You learn every day. You learn every day. Because you're a professor does not mean you do everything. If you don't keep up, your student will embarrass you one day with a question you have no clue. So we have to start that process of continuous learning. So that's my little contribution, Dr. Makwania. Thank you.
Thank you very much, Dr. Makwania and the presenters. I just want to make a comment to your question. You asked about the uptake of the QI methodology that we used in this project. Of course, what happened is we used the normal process because it was about adopting a tool to a country context. something that has already been proven to work. But I can say in the case of Kenya, we already have what are called the MNH standards of care, which in principle, it should be, standards-based audit is what is supposed to be happening at the facilities. Now the project just implemented a sub-component of that by specifically looking at PNC and the ANC. We did look into the intra-pattern elements. And so the standards as articulated by the government policy document is exactly what we replicated in the project. So I believe that the outcome of what we've done is supposed to guide how the ministry then would like to take forward this approach to improving quality of care. Thank you.
Finally, we are touching jigsaws in quality of care. And to be sincere, if you want to have a quality of care, somehow, somewhere, we need to introduce some kind of drills. And I can see an element of those drills. Instead of spending so much time making presentations, we engage with workers together, making sure the work is done while the supervisor is there. And somehow, we have managed in Tanzania mainland to simulate that. We have reduced so much on these didactic trainings. Actually, as I speak, a team of specialists, diversity specialists is there in Lake Zone, 3 zones, 3 regions, whereby they are working with the health workers in the district hospitals in every region. That means in all district hospitals, there is a set of experts who are working with them for about 7 days. And actually, they are giving service, but at the same time, they are training their fellow workers. And you will see it is working. And that one is addressing the 85% competence issue I showed you in the morning, in the graph. Because the ministry experts and decision makers sat down and said, what type of intervention do we want to put in place? So we said, maybe we send people so that they can work with their colleagues on the ground for a certain period of time, so that they can transfer some of their knowledge. And we are seeing some results out of that. This is not the first session, it is a 3rd session. We are conducting it twice a year. And when we do it for all 26 regions, for all 184 district councils. And that is a lot of fun, but when you do, as Professor Abe was speaking there, when you do the cost analysis, finally combining together with the clients who benefited from the service, we found that if you divide by clients, you found it's like 20,000 Tanzanian shillings. It is paying back. You will hear stories like, I've been living with this disease for how many days? But the most important thing is, you will get stories like, we reached about 4,000 providers in this session. So I think that is the approach we need to go, whereby we need to engage the health workers directly instead of giving lectures, which finally, they just throw them. Anyway. Okay, maybe we give the last hand of a clap for this team. Thank you very much for the work. Thank you.
But just give us a few more minutes and then we'll be done. I'm going to take a few minutes to make our presentation in terms of the results and impact. I think most of the elements of the program overview have already been covered by other presenters and other speakers who have come earlier on. So, yes. So the presentation outline is as you can see, there's a background, the approach, that is the interventions and the results, the challenges that we've experienced during program implementation, elements of sustainability, and hopefully they are trained that our video will show. On maternal health status, looking at Kenya, these statistics have already been alluded to by Dr. Bashir, who spoke earlier on. And I think the critical thing is that looking at the DHS 2022, our ANC coverage, our 4 ANC coverage, stillbirth attendance, all of this has significantly improved compared to the previous KDHS. But of interest is to be able to demonstrate the inequities in country is that looking at the stillbirth attendance, there is a big difference between the national average and the county-specific indicator, especially when you look at the county, Garissa County. The performance is at 68% compared to the national average of 89%. The other two program counties are fairly well. On PLC coverage, we are at 73% as a country. But you will see that still elements of PNC that should be given to mothers is still not necessarily provided. Okay, so this particular project in Kenya has been implemented in 3 program counties, as you can see highlighted in red. Garissa County, which is in the arid and semi-arid, that was highlighted by earlier on in the morning. One is a small county called Vihiga, and the other one is Uasin Gishu. The program covers 61 health facilities that comprise high and low volume facilities, some in the rural, some in the urban areas. Some of those facilities have high coverage of NC and PNC services, and some of them have high burden of HIV, TB, and malaria, but some places are not malaria endemic. And also there was reported, looking at the routine data, there are high cases of maternal and perinatal events happening in those facilities. So what are the results that we have been able to derive from this particular program? I think for us, I want to emphasize what has come through our interventions on there is the training of the healthcare workers, both on ANC, PNC, and specifically the quality improvement program using the standards-based approach to quality improvement. So we adapted the NCPNC manuals to align to country context as a measure of sustainability. The training package covers all the essential components of NC and PNC as per the 2016 WHO guidelines and the national guidelines. And the QI methodology is what has also been referenced in the MNH QOC standards for the Ministry of Health Kenya. The program was delivered through face-to-face, and also some sessions used the blended learning approach. In total, we have trained 357 healthcare workers in ANC and PNC with 42 master trainers. On the QI methodology, we have actually reached 323 healthcare providers with 30 master trainers. On mentorship, we have 45 mentors, and in total, the healthcare workers mentored are actually 270. And ongoing, coupled with that, those interventions for quality assurance, mentorship support, and the routine data collection that we have implemented on a quarterly basis. Looking at, when you specifically look at the standards-based audits, that was, yes, looking at performance of standards-based audit for quality improvement. No, we have to go back, sorry. Yes, performance of standards-based audit for quality improvement. So all the 61 health facilities, they have a couple of healthcare workers who are trained, and those went ahead to implement the standards-based audit. 92% of those health facilities completed at least two cycles of the standards-based audit by the end of July. And all those facilities showed an improved performance of an average of 44%. So in standards-based audit, we know that for each, once a facility does its problem analysis, they are able to identify a standard that they would like to improve on. And to be able to go about that, they gave themselves by undertaking what is called the first measurement. They assess where they are at the beginning, and then do an action plan, implement it, and then after a while, it could be a month, it could be several months,
look at their data again to confirm whether they are making progress or not. And as you can see from the data, on average, for each standard selected, between measurement 1 and measurement 2, the average was 44%. And these facilities, 57% of them on average would meet their target. And we say that the target is normally you aim for 80%. Once the standard has attained 80%, then it means the facility is doing well, they can proceed to the next standard. And since the standards are very many, the issues in facilities are different and varied, they are able to choose many different facilities for many different stations. Thank you. So looking at the data on the first ANC visit, we say that looking at the DHS of 2022, the national average was at 29%. When you look at the data from also the Kenya Health Information System, just the administrative data that is collected routinely in 2023, and looking at all the number of deliveries against the proportion of women who presented for ANC in the first trimester, it was just up to 18%. In the program counties where we were implementing this project, on average, we were able to move from a baseline of 18% to about 25%. In fact, there was a quarter where we were around 34%. So this is an area that still needs a lot of work because there are many missed opportunities when women come late for their booking in ANC. Regarding the first PNC within 48 hours, of course, the recommendation is that all women ideally should receive a PNC visit within 48 hours of delivery. So we combine this with the numbers of women getting a PNC visit versus those who got postnatal HB testing. And looking at that graph, you would see that yes, the women got the PNC visit because it is, we started at 65%, ended up at 87%. But when you look at it, those who got an HB test in Q1, at baseline we didn't actually have even the figure, but starting in Q1 it was just 2%, Q2 it went to 4%, and by the time Q6 of this program, we'd go to 29%. That is really significant progress, but it just tells you, that getting a PNC visit on its own does not say anything. We need to dig deeper to see what exactly the women receive. In the earlier presentation that Dr. Bashir made, it was stated in the demographic health survey that of all the women who had a PNC visit, only 25% had the 3 basic tests. That is, being told about postpartum family planning, being done, being checked, and just being having a discussion about postpartum discharge that normally every woman will experience, especially for post-delivery. So you can see the quality gaps become quite apparent when we combine these indicators. Proportion of women who are tested for HIV, malaria, and screened for TB. So you can see that when it comes to HIV, which is the blue bar, that one is already, we are doing well. We are at 98% as a country. But then when it comes to malaria and TB screening, antenatal specifically, the numbers are very low. Actually, for malaria, it's about 18%, and for TB, it's about 20%. So it means that we don't know whether it is because there is no index of suspicion or the people in the ANC do not think it is important to screen women. So that's a matter that at policy level we really need to look into it, because if we don't integrate, then missed opportunities are going to happen. Challenges experienced during the project. Of course, the project was only implemented in 3 counties out of 47, and only just small 61 facilities against the thousands of facilities in the country. There was inability to attain also 80% saturation in training. In most places, we just managed to get 40–50% at most. There was lack of key M&H equipment and supplies in some project facilities. So even despite the gap analysis and procurement of some basic equipment, some facilities still did not have the most basic of equipment. And doing quarterly M&E data collection, was also expensive in some places because somebody has to go specifically to facility, look at the primary registers, extract the data, and combine it, and especially during the flood season in April, May 2024. And of course, it was already alluded here in Tanzania, the issue of internet connectivity, which made it difficult for some participants to attend the blended learning sessions. Yeah, so the lessons learned from this yes, there were lessons learned, 3 lessons specifically I want to just highlight. One is that to maximize the impact of this capacity building of healthcare workers, there has to be concurrent engagement of other support structures like support supervision, procurement of critical equipment and essential commodities, mentorship and motivation of the healthcare workers. So you cannot just maybe design a program to just do capacity building on its own. It's unlikely that you are going to have any impact. It must be combined with all. So it means there has to be some focus built into the program so that you can address those other management factors outside the training of the healthcare worker. Secondly is the documentation of the local implementation experience and adaptations for innovative approaches such as the standards-based coding for QI and blended learning for capacity building are crucial to inform the broader adoption of the initiatives. So most of what we did in the project, it's already been proven to work elsewhere. The question is, how has it been adapted to the context in which we are working? If we do not document that experience, then it becomes very difficult to take it to scale. We want to move from 61 health facilities, maybe to 100 or more health facilities, but the question is, on what basis is that transition being made? And finally, the standards-based audit for quality improvement uses healthcare data at the primary facility. This is really an opportunity to strengthen the health information system because when the healthcare workers do their problem analysis, they use their own data. What is in their primary registers? How many of the women that came to ANC got their HB done or postnatal? What examinations were done for each of the baby? If healthcare workers can use that data, then it is going to be really useful to make changes because then they can action whatever based on whatever is emerging from their own data. Looking at sustainability is that this particular project leverages country momentum on UHC and has quality of health services as a key pillar. So it makes a contribution and whatever is emanating from here can be used to inform what we do going forward. It's also grounded on government policy. There is the MNH Continuum of Care, the MNH standards of quality of care standards. All this program is not running on the side, but it's building on all those. And then the project scope also leverages other previously implemented MNH programs. As LSTM, we supported a big program on building the common competencies in the country, training many workers across many different counties. And wherever this program has taken place, it is building on what has happened there. And the tools also used in the project are very useful because for something like standards-based audit, we have to come up with a tracker to really tell the stages of the status where each facility is at any one time. And that kind of a tracker, that particular tool that has just evolved within the project can be useful going forward. And also the capacity building initiative like the blended learning is quite cost effective, and I think that is something that can be taken forward even beyond the life of the program. So thank you very much for listening. I hope that video will be able
we have new guidance that the videos will play tomorrow early morning, and we allow the presentations to continue. Thank you, Dr. Ryan. Can I call upon Dr. Hawa Mohammed from Nigeria to do our presentation, and so that we don't miss the Zanzibar presentation. let them work on all the videos and give us an applause tomorrow morning. Thank you.
Good afternoon, everyone. My name is Dr. Mohammed Amoy, contributing for LSM Nigeria. I'll try and keep it very short so that we get enough time for tea break and I'm really looking forward to the talk of Stone Town, yes. So I'll really keep it short and brief. And if you have any questions, you ask me after watching the video, because I was hoping the video would tell you the whole story. But I'll just tell you a brief summary of what we've been doing in Nigeria. Okay, good. So I will really not go through all these statistics. We've heard a lot about Nigeria today from the previous presentations. But I just want you to know that currently our statistics regarding maternal and newborn health is not very good. Nigeria has the highest number of absolute maternal deaths in the world. And there's a wide disparity of these deaths between the northern and southern part of Nigeria. There are, the way the health system operates in Nigeria, I'll tell you about that briefly, is that each level of healthcare system, plus the tertiary, secondary, and primary, are financed and managed by different levels of government. So the tertiary health system is under the federal government of Nigeria. The secondary health system is under the state leadership, and the primary healthcare system is under the primary, or under the local government area, but there is a national primary healthcare board and state primary healthcare boards. So the program started in Nigeria in 2020, and we're supporting two states, Kaduna and Oyo State. Kaduna is in northern part of Nigeria, and Oyo State is in southern part of Nigeria. Both states 60 healthcare facilities are supported, and most of them are primary healthcare centers. This was selected with consultation from the Ministry of Health. As you know, the primary healthcare centers are closer to the populace. That is why that is selected, and we work in close partnership with the Ministries of Health and primary healthcare development agencies of both states. So we did a baseline survey in 2020, but because the program started first in Nigeria, we did not have the pleasure of having the quarterly M&E evaluations like other countries. So we only had a baseline which was done in 2020 and then an endpoint assessment at 2023. So during this period of the program, essential equipment was supplied to all the 120 facilities in Nigeria, and we trained 802 healthcare workers in antenatal and postnatal care and 330 in quality improvement. So for the standard-based audit results, 90% of all the facilities that we have supported completed at least one audit cycle. And when you look at the number of audit cycles that were completed, there were about 146, and this is just a range. There is a facility that completed as many as 16 standards, and some completed just one. So some of the actions that were successfully implemented mostly included facility improvements, such as things as simple as providing chairs for antenatal women, repairing toilets, and also repairing some equipment that were spoiled in the facilities, and also improved service delivery, such that we've talked about a lot of these tests that were not done before. I will talk about that later. There's improved data management and improved staff attitude, especially introduction of respectful maternity care, which you will see a lot of that in the videos that we're going to show you. And one important thing that happened with this is during when facilities were trying to get their quality improvement, mentioned, they involved members from the community. So there is something we call the Ward Development Committee in each local government area. They were able to get members of this community into the quality improvement team, which made it easy for community outreach. So these members went back to the community and encouraged women to attend antenatal care. So this is just an example of some of the standards that were audited in the facilities. So, antenatal care, as you can see, in both Kaduna and Oyo State, there was about 50% increase, or a little bit more than 50% increase in the number of women that attended antenatal care, and that would most likely be from the community outreach done by the World Development Committees. But as you can see, the number of women attending antenatal care before 12 weeks has not changed, and I'm not surprised it's the same. And we have the same belief too, especially in northern Nigeria. Even you don't tell anybody about the pregnancy, not even the husband, until at least after 3 months. So that is our belief too. So you can see, and the average in Nigeria is 11%. So it's not different from this. So this is something that I think all countries will need to work on. So some of the other results that we have seen, the number of deliveries, there's about 70% increase in the number of women coming to deliver in these facilities. And like I said, this is all from the community outreach through the quality improvement team. So TB test was actually not done before this program. Most of the, especially in Oyo State, in Kaduna State, some tests were done, but as you can see, there is some increase in TB tests. Malaria testing too was already only done for women that were symptomatic. But after the training, every woman coming for booking is tested for malaria. As you know, a lot of programs are supporting HIV programs in all the countries, but you can see HIV testing has increased to almost 100%, which is quite significant. And the rest of the results I've already talked about. So the lessons we learned from this is that this capacity building and leadership is really something that health workers are willing to embrace. So when we talk to most people, they will tell you that health workers are not interested in what you're doing. They are not interested in any training opportunity you bring to them. But what we have found out with this is that health workers are really willing to embrace change, and they are very receptive to mentorship training. Some of these people that receive award from Nigeria, the mentors, these are people that have really taken their time, not only to mentor people within their facilities, but they spend their money to travel to other facilities to go and mentor people, and it's really receptive. And then we know that there is a need for expansion for this program. I mean, other countries are talking about the need to expand, but I mean, when we talk of Nigeria, we have not even scratched the surface. Kaduna State alone has 1,500 functional primary healthcare centers. And we went to only 60 facilities in the whole of Kaduna. And same thing with Oyo State. And we talk about Nigeria as a whole, so we really need to expand. So for sustainability, we're lucky there's government ownership. I was discussing with the person from Kaduna State. They've already started implementing the National Quality of Care program in Kaduna State, the one that the person from the Ministry of Health presented this morning. And they have also just started the state mentorship program. So at least we're sure that most of the work that we have done will be sustained. So the challenges is the same as other countries. Definitely we have staff shortages. And in Nigeria, I don't know if you know the JAMPA syndrome. JAMPA is people running away from Nigeria to other countries. So most of the health workers have left. I think about 2 weeks ago, 3 weeks ago, we had another program and we're talking to the registrar of the Nursing and Midwifery Council of Nigeria, and he said last year alone, 14,000 nurses and midwives left Nigeria. The ones that they know about, 14,000. So you can imagine, that's a big problem. And then excessive workload, because we don't have enough health workers. And then we have a very huge population. There's too much workload for the staff. And then from frequent transfer of trained staff, I think this cuts across all the countries, inadequate infrastructure and equipment. And then we've just had a big blow in Nigeria. We have serious issues with our economy. So it's difficult for people to even get transport money to come to the hospital, not to talk of being able to pay for services. So that is also affecting how services are rendered in Nigeria. So in conclusion, the Quality Improvement Program in Nigeria, in partnership with all the state ministries of health and authorities, it complements the grand plan of the Federal Ministry of Health and the states, but there is need for regular monitoring and evaluation, which will ensure the program's success and sustainability. And hopefully from the insight we gained during the headline assessment, it will be valuable for program and stakeholders and advocacy in enabling informed decision and development of new program for enhanced impact. So we are really grateful to all our partners in Nigeria and to Zantli Medical Services for being our administrators in Nigeria. And thank you.
Thank you, Dr. Hao, and all the presenters. It has been a tough afternoon. I promised to take a very short time, but I don't believe I have fulfilled that promise. Basically, I think the technological reach also contributed to that. We have said that for the videos that have not been shown, we'll work on them tonight, and hopefully tomorrow we'll show it before the sessions begin. You have seen the impact of the programs and the trainings that have been undertaken in the 3 countries, and the 4 sites. The underlying factor is that there are specific challenges in terms of human resource, the transfers, the exodus in different countries, and the availability of specific equipment in specific places. The cultural impediment of first ANC visit in the first trimester is cross-cutting, and improvement in that area requires maybe a different strategy and maybe a more in-depth study on what is the issue and how can we navigate that area. Internet connectivity is also cross-cutting, therefore the more reasons why we should have a multi-sectorality in approach, a whole government approach in terms of providing the equipment. The Ministry of ICT is not on board, the Ministry of Transport is not on board, and therefore the health sector alone, whether it's state or federal, alone doing interventions will not be our final solution. Health has its own social determinants, and I think we need to broaden the interventions to involve multi-sectoral approach, not just the stakeholders, but different government ministries. If there is power, electricity, and internet in all the facilities, that is not a mandate of health, but we have connections to them, and therefore we scale up and escalate this to a higher level where the cabinets maybe discuss the health issue and connectivity and digital health and all the rest. Issue of data in terms of maternal mortality ratio and infant newborn mortality. Data quality has been mentioned, and therefore the more that we digitize our health records, the better reliability and accuracy can be really counter-checked by others. So unless, I don't believe you should have questions knowing that you've used your team, but if there are burning questions to the panelists, I will welcome one or two.
Thank you so much. Let me congratulate the presenters for a very good job. You have done justice to it. Thank you so much. I think you talked about the first ANC visit, which is cross-cutting. That's exactly what I want to discuss. I think one of the reasons that was given is that probably disclosing pregnancy early in probably will lead to pregnancy loss. I think I heard that from one of them. I think probably we need to look very deep down. There could be, because you talked about other reasons. There could be other reasons. To me, it might not be the only reason why they're not coming for the first antenatal visit. Let me give you an instance. I worked as a medical officer of health, and I was transferred to a rural community. When I got there, the first thing I noticed that there was a particular facility that had a very low patronage. So I began to wonder what could have led to this. So I called all the staff in the department that, did you observe this? They said they observed it, but they have been trying to provide solution to it, but they couldn't. So I looked at it very critically. You know what I did? Because to me, there wasn't enough demand creation for them to have moved into the air facility, at least for the first ANC. So I went to that community and met with the stakeholders there, the gatekeepers. And I told them that I would like to have a meeting with the community members, because I needed to do a root cause analysis. Why are they not going to that particular facility? We have trained all the air workers there. Still, they didn't go. Lo and behold, what we overlooked was the reason. And what is that? I had all of them. The women were there, the men were there, all of them assembled. Did you know what they gave as a reason? Almost all the men that were there, they said that we will not allow our women to go to that facility, you know, to put to bed. And I said, why? They said, why did you post a male nurse in that air facility? That's why they didn't go. So at the end of the day, I posted that person out. In fact, the following month, come and see people that visited that particular facility. What I'm saying is that we need to look very inward and see if there are other reasons why they are not going to that particular facility. Then again, we need to bring on board our men, because that, to me, that's a part one delay. That's a type one delay. So we need to bring them on board to tell them that there is, if possible, they will bring results from other communities or other countries where they have high first ANC visit compared to where they don't have. So when we compare and contrast and they see that there are better outcomes there, probably that will even convince them to even allow their women to go, you know, to the facility for ANC. Then, again, I want to ask, you talked about sustainability, because more often than not, at times when partners come to a particular country, LSTM, definitely they have come to meet us, and I received them, and we have discussed very extensively. But more often than not, they don't actually get the buy-in of the ministries. Buy-in in the sense that the people, the critical stakeholders, the policy makers, most of them, at times, they don't know what actually transpires. But I think this gap has to be bridged so as to have the buy-in in order to have effective implementation. Thank you.
Okay, so thank you very much, Dr. Bashir, for chairing that session. We appreciate. I do not have much, but I just wanted to say that since most of us have come from very far and we are interested in at least having a taste of Zanzibar while here, we have identified some key places that people could potentially visit. I'm not sure if it will be possible today, but at least for tomorrow or the day after, there will be schedules at the back of the room so that people can register early in the morning to say where they want to go, and then they will be advised and guided on how much or what they need, and then so that at the end of the sessions in the evening, people can go and at least go to some place and see the beauty of Zanzibar. Thank you and good evening. Enjoy your coffee.
Thank you so much, Dr. Henry Jumbo. So, at the end of that presentation, you will agree with me, it's not for lack of trying. The strategies are plenty, they are comprehensive, it's a large country, 230 million and counting, and a complex health system. So not for lack of trying, there are lots of strategies, and it touches on a lot of those WHO recommendations which we have talked about previously. So I think the encouragement to very large countries like Nigeria that are making all the effort is that looking at some other countries that are even larger, like in South Asia, the likes of Indonesia and the Malaysia, in spite of the similar complexity, they have been able to make progress. So I think it's to really keep up with that approach, and probably the results will come in time. So one thing is clear. I think they have realized that there's a need to focus on quality of care, just like all other countries, putting in place a comprehensive strategy to quality of care, and also addressing some of the health financing issues, investing in the health workforce, and addressing some issues with financing, trying to reduce waste, harmonizing of plans between partners, and to make sure there's no duplication, and then also trying to gain some efficiencies through pool procurement. That's very important. And lots and lots of efforts around improved availability of data, starting at the tertiary healthcare facilities with the EMR, and encouraging the states, to trickle this down to their own facilities. So one thing you can say, it is a complex problem. Nobody ever said reducing maternal deaths is easy. Once there's a leadership and once there's a way, I think eventually we are going to hit results. So from WHO point of view, if you can crack the problem in Nigeria, you're going to make progress. So the target for reducing maternal mortality ratio globally, less than 70 per 100,000 live births, is a global target. So if you can focus on 10 of the countries with the highest contribution to this, you're going to make an impact. And Nigeria is one of those countries where there's a lot of focus from WHO to help shift the needle. But I'm sure with the excellent leadership provided through the Federal Ministry of Health and the Minister, I think we're going to see results soon. So big round of applause for sharing the experience from Nigeria. So last but not the least, from our hosts, it is my pleasure to introduce my brother and my friend, Dr. Slim, Director of Prevention and Health Education, Ministry of Health, Zanzibar, to give us the experience and the perspective from Zanzibar.
Good afternoon, before we were still in the morning. Thanks very much. In Zanzibar, we're not really far away from Dr. Mkwani, but Zanzibar is very contrary to Nigeria. We are only 1.8 million people here. So we probably not even bigger than Abuja. Yeah, so majority of our intervention are not really complicated to deliver because of the geography and the size of population that we get. In the whole year, we probably will have approximately just under 60,000 women delivering babies in our hospital overall. But the challenge associated with maternal and reproductive care, probably they don't really differ. Yeah, because that's just the way it is. We are in a long country, and I believe one of the situations that our government is put commitment is really to invest in the health of women and children. That's one of the paramount important agenda in our government. And if we go back to 2019, any women in Zanzibar, we have two levels of facility that we have care. We have primary health care, then we have straight referral, where it was very complicated. With only one referral hospital, it was difficult, depending on where you are, to get to the facility for referral in case you have any complication. But 2020, 2021, we made an aggressive approach to reform of healthcare, and within our 11 districts, we build each district with their own district hospital where people should really deliver receive care on where they live. So if someone is on point X, it doesn't matter where you are in Zanzibar, within 1 hour 20 you will be there. So if someone tells you you'll be there 2 hours, in Bogo, not in the island, right? So what happened, we make sure that we decentralize service to the community and really help to cut down the immense pressure on referral hospital. But that came with challenge because after building this 11 hospital, we need to equip them, but also we need to staff them. And SUSA is the only institution we rely on to produce its experts in Zanzibar. And fortunately, by the time we set them up, they were ready to go, and we decided to make sure that to provide consistent service, especially in reproductive health, we need to find a mechanism to sustain our service by partnership with a private company to help us in imaging, laboratory, and other area of diagnostic. So that's really worked well. But the challenge in Zanzibar, we are very lucky that for HIV and malaria, we are both at almost level 0 point prevalence, right? So we managed to get malaria almost to eradication phase, and our HIV prevalence here is almost beyond that, less than 1%. And therefore, one of our biggest challenges is profound maternal and perinatal death. That's where we struggle, and we try to thrive to overcome it. The reason, I believe, contextual, we can categorize it into two forms. There are problems that are associated with the community, right? I believe the community, they have their own responsibility in terms of that. Issues such as family planning, and Zanzibar has really low prevalence of family planning. That is confounded by social norms and other parameters. So, and also we witness that based on our data, majority of women, especially in terms of number, around 47% of women of reproductive health in Zanzibar are anemic. And this is really bad. And obviously, one of the causes of anemia is nutrition. And if a woman who is anemic becomes pregnancy, it poses a great challenge to herself but also to the health system. But furthermore, if the same woman then does not space, right, it really causes more of complication. That's where we're facing And we still try to try, but we don't have enough ODGY specialists to overcome the challenge. So to recognize that, we also monitor that women don't tend to seek care as early as they should in Zanzibar. So this is again could be driven by the norms and other parameters. What we've done is before there was a need for us to establish a way where we can able to touch each and every one of these women at their household level. And we have invented a community health worker who are actually visiting every household to take necessary test of indicator at the household level, but also promote healthcare to allow women to improve their health-seeking behavior. Doing so, we have seen upsurge of number of people seeking care earlier that somehow has helped us to consult them and help them with improving their nutrition and hence their reduction of anemia burden. So we are seeing trend of improvement, and obviously there is enormous work to be done. But the challenge that we are posing now, they are at the level of community but also institution. In terms of community, we continue to engage in educating them, including men, such as engaging men to come into ANC with their partners so that we embedded education about family planning so that they know what they need to do by the time they have their baby and the importance of spacing between the baby, because maternal mortality, at least 60% of them are prevented with very small measures. If we put a woman in family planning, good nutrition, and good healthcare system, I believe majority of this maternal mortality here in Zanzibar that are happening can be prevented. We are still stagnant at 145, and we really wish we could able to move the needle to the hashtag and achieve more, but we partner with UN partner such as UNFPA to support us through maternal family planning. We have UNICEF on board that are supporting us, but also most important is to improve quality of care that we render at the facility. Doing so, that's why we say we built almost completely brand new 11 brand new hospital at 11 districts in Zanzibar, but also we hire or we go into partnership to ensure that the care that we render to the community who attend care is consistent, but also continue elevating family planning and more training to our nurses. We are very lucky that every nurse that we get will probably be exposed to enormous training that we are hoping that training will improve the quality of what they are providing to the clients. But also, Zanzibar is almost digitalized in terms of how we capture our data to allow us decision making. Those 48% of anemia that I've told you about obviously came from the data that we collected. But epicenter of those areas are also well known. They are based in northern Unguja and northern Pemba. So we now mainstream our intervention to those areas because we know for sure there are some areas where we are more likely to have healthy women, but those particular regions between both islands are very privileged. They've got high privilege of anemia in relation to their women. So our pressure and throttle is going towards those areas. But furthermore, Zanzibar, to unify how we deliver care, we adopted universal health coverage, and we have what we call Zanzibar Social Health Fund. This funding mechanism allow everyone to be given care in respect of their economic status, right? So any person who go to our facility in Zanzibar, especially women, they will be given the service for free. And we make sure that service is available. If you look at the parameter for those who attend care, the level of hemoglobin and blood pressure monitor and other parameter, that score is almost 90%. Yeah, so meaning if you attend to a facility, the likelihood that you will receive the minimum package as a pregnant person, a pregnant woman, will almost go beyond 90. That's because we have tried at primary health care level to make sure we have commodity, but also in the district and tertiary hospital, we have privatized our service to make sure those vendors do provide service to our public and at high quality level. So we try our best to kind of work together with our partner. Thanks for UNFPA, LSTM, for your support that you have rendered to us, because your immense contribution has really reshaped and helped us to reduce the maternal and perinatal death in Zanzibar, because I don't believe there is one size modality that will go out there and reduce the maternal and perinatal challenge. We require family planning, we require nutrition, we require high quality of care, we require training to our service provider, but we require commitment at all levels and also community ownership to really understand the magnitude and what they really need to do, because there is a huge difference between a woman who understands reproductive health and those who don't understand when it comes to the outcome of the trend of description in this topic. So Zanzibar, we're making stride, and obviously we're looking forward to continue to partner with anyone that has got interest in investment in reproductive and maternal health in Zanzibar. Our doors are open, and we will continue to communicate and collaborate with any partner. And thank you very much for that.